Oh, yeah, I know.
Ready? I don't see the time anymore, but I think it's after 12.
Yeah, we're a couple minutes after.
Hello, everybody. And welcome to our final Engel Rounds session of this academic year. Before we get to what it is, I just want to remind people, if you're watching this by Zoom, looks like about 64 people so far. Make sure to not send any messages through chat because that's reserved for the panelists and the AV team and the interpreters. So we hope people have questions, comments, and just put those in the Q&A box. And then at the end, we'll read them in order. Also want to remind people to fill out the evaluation at the end. There'll be a link that comes up on a slide and a QR code, and then an email tomorrow. It's very important we get people's feedback about the programs here. And that takes care of the housekeeping portion of today's program. And now I'd like to introduce our speaker, who is Dr. Jessica Keith, who's a clinical psychologist, senior instructor in psychiatry, director of the department's autism programs, and someone who's done some very interesting research on young people with autism, especially around diagnosis and psychophysiological markers. I've had a chance to work with her a little bit, and I'm really excited about the work that she's done and is planning to do in the near future. Her talk today is called The Impact of Sensory Differences on Development, Functioning, and Mental Health in Autism. And without any further delay, Dr. Keith.
Thanks. Hi, everyone. Thank you. I really appreciate you being here today. Oh, is that better? Yeah, okay. To give me your time and attention. I know those are resources that you don't have a ton of, so I appreciate that. So as Steve said, I direct our autism evaluation service at Pediatric Behavioral Health and Wellness. And through this role, I evaluate patients within our clinic for autism spectrum disorder. So I'm going to be referring to that as either autism or ASD throughout the presentation. I'll use them interchangeably. All of these patients that come to me, they come with existing mental health diagnoses, and most of them are school age, adolescents, and even young adults. I'll be sharing stories about a few of these patients throughout the presentation, and I'd like to start by talking about Mary. So I evaluated Mary when she was 9 years old, and during the developmental interview with her caregivers, Mary was described as a young child who often played by herself and who lit up around dogs. In fact, while other children at daycare were playing together, Mary was consistently found playing with dog stuffed animals. On the playground, Mary was happy swinging by herself. This description of Mary highlights a well-known but often misunderstood component of autism: decreased social motivation. There's an entire theory of autism called the social motivation theory. And importantly, this theory does not suggest that autistic individuals simply do not want to be around others. It instead pulls together research that sometimes inconsistently demonstrates early onset differences in that natural pull towards social input. This reduced social approach motivation is broken down into the categories of reduced social orienting and social attention, reduced social reward processing, and reductions in the behaviors that lead to the initiation and maintenance of social relationships. These differences are theorized to influence developmental processes that reduce social learning experiences, which then go on to alter social skill and social cognitive development. But as someone who works with patients with autism and was trained in a lab that examined sensory processing differences in autism, this theory seemed to be missing a big piece of the autism puzzle. Because when I look at this scene, I don't just see a child that is less drawn toward other children. I see a playground that is almost certainly loud, filled with children running around in unpredictable ways, a parent talking on their phone, playground equipment that's sometimes cold, sometimes scalding hot, etc. And whether it's playing with kids at recess, talking to other classmates in the lunchroom, or as an adult, meeting up with coworkers for happy hour at a bar, the sensory characteristics of social interactions are complex, unpredictable, and often overwhelming. So in my attempt to find and explain that missing puzzle piece, I've developed a small but growing program of research that examines the relationship between sensory dysregulation and social functioning in autism. I also wanted to examine the possible mechanistic role of self-regulation or executive functioning and physiological or autonomic regulation. Because put simply, if a person is overwhelmed by social sensory input and is unable to utilize adaptive methods to self-regulate, they can avoid social interaction and/or suppress their feelings and behaviors to fit in. The former strategy, avoiding interactions, may be that missing piece of the social motivation puzzle that contributes to social difficulties beginning early in development. The latter strategy, suppressing or what is sometimes called autistic masking, may be why we see so many comorbid mental health challenges in autism. And here is that full picture from my mind, just put down on the slide for you. And here's a quote from a past patient who summed up this model perfectly while explaining his experience. Sometimes if it's noisy or everyone is talking at once, my thoughts go this way, and I feel anger and stress fueling up. I want to start hurling insults, but I usually just walk away. So here we have social sensory input that leads to cognitive dysregulation and affective dysregulation, which is then ultimately managed by avoiding the social interaction. And then here's a quote from a really great paper that examined the sensory experiences of adults with autism. Quote, "I am quite a hermit these days because I avoid being in those situations if I can. Even family get-togethers, I'm not normally there too long." So next, I'll walk through some of the results from 4 studies I've conducted that have begun to examine the model I just discussed. I'll be sure to discuss clinical implications, or what I'll be calling tangible take-homes for each finding. The last portion of today's talk will briefly describe what I hope to be my next project. So my first study examines the first piece of this model, and it is entitled "The Impact of Sensory Stimuli on Autonomic Regulation and Attentional Processes in Autism." As many as 96% of people with autism have atypical sensory processing. And when studying sensory processing in autism, people sometimes conceptualize difficulties overall, as well as across individual sensory domains. Another way to think about sensory processing difficulties is using a dimensional model where individuals can be hypo all the way to hyper responsive to a stimulus, meaning that they may over or under respond to a stimulus compared to the general population. The majority of child and adolescent sensory processing research has been conducted using parent report questionnaires. And this method relies on indexing sensory processing via observable behaviors, which may oversimplify that relationship between behaviors and basic sensory processing mechanisms. It is also subject to reporter limitations such as memory or bias. Those things considered, parent reports have provided really important insight into the impact of sensory problems in the daily lives of individuals with autism. And those findings have shown us that sensory processing difficulties are present across the lifespan, that they have an impact on adaptive functioning, and that sensory symptoms tend to correlate with overall symptom severity. Another method of measuring sensory processing in autism is using laboratory paradigms, which allows researchers to carefully study specific sensory processing components and examine potential mechanisms. One promising area of laboratory research is looking at the autonomic nervous system in response to sensory stimuli. So for this first study, I looked to rigorously measure the sympathetic and parasympathetic response to controlled sensory stimuli across sensory domains. I was specifically interested in the cardiac orienting response to the stimuli, which is that initial deceleration of heart rate to novel or interesting stimuli that allows more oxygen to flow to the brain and is linked to attentional processes. Participants were adolescents with and without ASD. The groups were matched on age, verbal IQ, and gender composition. IQ ranged from 84 to 133, and the average full-scale IQ is about 110. I used an established protocol to deliver sensory stimuli. It's called the sensory challenge protocol, and that involved multiple 3-second exposures to a tone, then a strobe light, siren, wintergreen oil, and a feather moved along the participant's jawline. During that, heart rate and respiration rate were collected continuously. I then used a group by trial repeated measures ANOVA to examine overall cardiac reactivity and orienting responses across all sensory domains and within each domain. Collapsing across all trials and sensory domains, the data revealed a highly significant group by trial interaction, such that individuals with ASD are overall less reactive, to repeated sensory stimuli. Now, if we zoom in to consider only baseline in those first 2 sensory trials in each domain, the data again revealed a group by trial interaction, such that individuals with ASD demonstrated a significantly decreased cardiac orienting response to novel stimuli. Finally, a priori analyses within each domain revealed group by trial interactions for responses across all trials for tone, wintergreen, and feather, and for those first few trials for tone, wintergreen, and siren. So what does this mean? Just a quick review. So this was the first study to look at autonomic orienting responses to sensory stimuli in adolescents with autism. And it really showed us that there's sensory under-responding that's linked to attentional processes. And it might impact those individuals' attention toward basic stimuli in their environment. Clinically, this could look like a lot of things. So one of the classic first sort of red flags for autism is not orienting when someone walks in the room and starts talking or calls a person's name. So that has a connection with what we found here. Also, under-responding or not noticing to input like cold, pain, touch, or needing to use the toilet. We also might see an individual compensate by seeking out more stimuli or more sensation. So that could look like an individual humming to themselves, crashing into furniture, spinning to get that input. And then really importantly, if an individual is not noticing those low-level sensory stimuli, the stimuli around them are likely to increase and increase and increase until it gets to something that's more intensive that then they notice. So imagine that mom that's saying something to their kid and calls their name, and all of a sudden that kid finally tunes in when the mom is yelling. And now it feels really aversive and shocking. So that's something that sort of links that more hyper-responsive pattern to this hypo-responsive one we saw here. And then as promised, each study will have a tangible take-home box to bring back to the clinic. So from this study, I'd like to recommend that there's psychoeducation with caregivers about that connection between sensory processing and attention. It would be helpful to direct people to get someone's attention by getting at eye level with them and calmly making sure they're attending to you before giving a command to avoid that escalation to yelling. It's helpful to use predictable visual cues as much as possible to satisfy that maybe seeking or need for additional sensation. A clinician could recommend using fidgets, sensory cushions, headphones with music. And then, of course, using prevention strategies is really helpful. So if someone's not noticing pain or they're not noticing danger in the same way that someone else might, then that's up to us to control the environment to keep them safe. Here's another little tool I wanted to share with you all as something else you can bring back to patients. So this is going to be an assessment approach / tool that I find really helpful when learning more about an individual's experience with sensory input. So I use this in therapy a lot and also in feedbacks with families after an evaluation. It's important to know our individual experiences with sensory input on a day-to-day basis are kind of all over the place. And that's especially true for individuals who have sensory processing differences. So it's really not as simple as a parent being able to say, yeah, Joey doesn't tolerate loud noise, period, across the board. And parents are often confused by that because it's hard to predict or understand why something may be dysregulating or regulating to their individual child. So I find it helpful to use an axis system with a vertical arrow that represents the individual's physiological response to stimuli, from being over responsive at the top to under responsive at the bottom. Then I add a horizontal arrow that represents the behavioral response, running from a person avoiding stimuli to seeking out that stimuli. Then I'll talk with the patient or their family and start to plot individual stimuli within this system. So for example, here are some stimuli that I could plot from a recent evaluation with a 15-year-old non-binary patient. As you can see, important stimuli to that patient gets plotted all over this system. And then you can use this as a tool to discuss it more with the family. So it and the person themselves. So it feels a little clearer why, let's say, a loud noise in the environment that's unpredictable is considered aversive and something the person wants to avoid. And yet they themselves are super loud. And so that's also loud, but different because it's controllable and predictable to that person. So give it a try, see if it's useful for you too. All right, so that first study connected autonomic sensory processing to attentional processes. And this next study dives deeper to directly examine how auditory sensory input may impact both autonomic and cognitive functioning. So there are a lot of different areas of functioning, but in childhood and adolescence, possibly one of the most important areas is learning and cognitive performance. And academic environments vary a lot, but the noise levels in a typical classroom are loud. That's important because noise has been found to degrade performance, particularly when the noise is loud, intermittent, and complex, and when the task the person is working on is challenging. The mechanism behind that is still unclear, but some have theorized that noise impacts the level of autonomic arousal, which then impacts cognitive processes. And there might be this optimal level of arousal seen on this graph here, such that higher arousal during a less challenging task is helpful, but that lower arousal during a more challenging task is what's ideal. And it's also important to note that the optimal level of input and arousal for any given task is going to depend on group characteristics as well. And because of that, it's important to note that numerous studies have demonstrated substantial and prevalent self-regulatory difficulties in autism. So when I refer to self-regulation, again, I'm referring to both more of that cognitive side through executive functioning and that affective side of self-regulation. And we see difficulties in both areas in autism. So it would make sense that this population would be more greatly impacted by noise. So for this study, I aim to investigate the influence of noise on a working memory task in ASD. while also examining the role of autonomic arousal in this relationship. To do this, I paired either no noise or background noise with an easier and harder level of a visual span number task. The noise was an intermittent broadband noise presented at 75 decibels, and it sounded kind of like like that. Very annoying. And the entire time they were completing these tasks with and without noise, I was measuring the autonomic nervous system response. So I wondered how varying noise and difficulty levels would affect performance and autonomic responses in adolescents with and without autism. And this is a little blurb on the participants we had for this study. So you can see they were really well characterized. So for the cognitive performance results of this study, we found a main effective difficulty level such that both groups performed better in the forward span condition than they did in the backward span conditions. There's not a main effect of noise, but there was a significant two-way interaction of noise by difficulty, and that's what's depicted in the graph. In the graph, you can see that the total score for the span tasks is on the y-axis, so higher is going to be better. And the ASG group is in black and the control group is in gray. So as you can see here, people across both groups tended to do better with noise in that forward span, the easier task. And they were marginally affected by noise in the backward condition. And that supports a differential impact of noise depending on task difficulty, like we had predicted. Next, I examined the autonomic results. Heart rate analyses controlling for baseline heart rate indicated increased arousal across groups with the addition of noise in the forward span and a differential effect of arousal between groups and backward span. Skin conductance analyses, indicated significant main effects of difficulty and noise, which supported our difficulty and noise manipulations, but there were no interactions with group for skin conductance. And next, I wanted to more directly compare the relationship between arousal and performance with the addition of noise. So first, I created performance and autonomic change scores. A higher performance change score meant that that participant did better in quiet relative to noise. And then a higher arousal change score meant that that person was more aroused in the noise condition relative to quiet. Heart rate and skin conductance change scores were then correlated with performance change scores. Increased heart rate was associated with better performance on forward span when the noise was added for the typically developing group. A different pattern emerged for skin conductance, whereby increased skin conductance from quiet to noise was related to significantly lower scores on backward span for the autism group. So what did we find here? Noise improved performance on that easier task for both groups. And then noise increased arousal in the easier condition for both groups, and then it further increased arousal for the autism group on that harder condition. And we see that increased arousal related to better performance for typically developing teens on the easier condition and worse performance for autistic adolescents on the harder task. So tangible take-homes for this study. Self-regulation interventions that modulate arousal levels during a cognitive task may support improved performance. We would probably all have guessed that. But I think when we think about self-regulation interventions, we often think about down-regulating an individual, calming them down more. And this study really shows us that sometimes we have to increase arousal to support performance. So that could look like having someone listen to music while they're working on homework, having a wobble seat, fidgets, walking. Walking's been shown to really help performance. But for those people where we do need to decrease arousal, consider diaphragmatic breathing, talking back to worry thoughts, taking a break, positive imagery. I mean, we could go on with a list of self-regulation interventions. And again, psychoeducation to parents, teachers, the individuals themselves, really aimed at helping that person get better at identifying where their optimal level of arousal is. so they can flexibly alter that in the moment using those strategies I just discussed. And then a quick note, I wanted to make sure to share that we have to be careful about the kind of stimuli that's around a teen. So having a phone next to them with calming music is one thing, but if there's alerts coming through and notifications from social media, I'm sure we would all agree that that's going to be too emotionally laden to be supportive in these cases. So really walking through and thinking through what those interventions will look like in real life will be important. Okay, so now we've looked at how sensory input impacts physiological regulation, attentional processes, and executive functioning. For my next study, I looked at the relationship between social sensory input, self-regulation, and social motivation. And my overarching hypothesis or inspiration for the study was that the combination of increased reactivity to social information and significant difficulty effectively modulating these reactions in social environments may, over time throughout development, lead to meaningful differences in social motivation and autism. So this study was really two studies. The first, a parent-report examination of sensory processing, self-regulation, and social motivation in a diverse national sample of children 5 to 8 years old. The second is a pilot study that tested the feasibility of examining these same constructs, but in the lab using really cool, innovative methods that I'm excited to share with you. So here's a quick peek at the participants for the first AIM, as well as the standardized measures that were used. As you can see, we had 55 parents of children with autism and 60 parents of typically developing children complete the online survey. And that survey was comprised of sensory, executive functioning, and social questionnaires. As expected, group comparisons revealed significantly lower social motivation in autism, higher sensory symptoms in autism, higher levels of cognitive dysregulation in autism, and finally, higher levels of emotion dysregulation in autism, all compared to the typically developing group. Not a big surprise based on what we know already. Next, I examine the relationship between self-regulation processes and social motivation, as well as the relationship between cognitive and emotion dysregulation. All three associations were hypothesized to be moderated by group, with the effect being stronger in the autism group. Results supported a significant relationship between cognitive and emotion dysregulation, with significant moderation by group, but it was a little different than what we expected. The effect was actually stronger in the typically developing group. Here, we're looking at the relationship between each form of self-regulation and social motivation. So cognitive dysregulation significantly predicted social motivation, and emotion dysregulation marginally predicted social motivation. Neither association was moderated by group. And while my hypothesis that these relationships were stronger in autism did not show in the data, I think this finding is still really important. And it suggests that both cognitive and affective regulation directly contribute to social motivation development in all children. And that when we're thinking about social motivation interventions, we should consider self-regulation as important for all children. I then examine the relationship between sensory symptoms and social motivation, with cognitive and emotion dysregulation as possible mechanisms in this effect. This first slide shows the models with cognitive dysregulation. So the indirect effect was found significant in the ASD group only, which confirmed or was confirmed using asymmetric confidence intervals. And while this data was collected at a single time point, it suggests that sensory symptoms may play a unique and significant role in decreasing social motivation, and that one way sensory symptoms may be associated with this in autism is via disruptions in cognitive regulation. This next slide shows the indirect effect model for sensory symptoms predicting social motivation through emotion regulation, and neither the ASD model nor the TD model demonstrated significant mediation. All right, here's the fun part. So now we're going to talk about testing these constructs in the lab. In just a small pilot sample, we had 14 kids, some with autism, some typically developing. So I'm going to really briefly go through the tasks I use, but I am happy to talk about it afterward if you'd like to know more. The choose a movie task was used to measure social motivation. It's a social viewing effort expenditure task where for each trial in the task, children are instructed to select which box they would like to open to view a short video clip. So in the training phase, they're taught that orange boxes always correspond to social videos and that the blue boxes always correspond to non-social videos. It's like picture a household object on a lazy Susan that's just sort of going around. Okay. They're also taught that the number of locks on each box corresponds to the number of times they're going to have to click and then wait for that box to open. There are 30 trials or test trials for that one. And it was developed to assess social motivation in autism, and it has actually identified a preference for social stimuli in neurotypical adults, as well as a preference for objects over faces in teens and adults with ASD, and that was correlated with their social functioning. The wearable BioPack bioharness was used to collect autonomic responses during all tasks, so there were no wires involved. And the flanker task for children and visuospatial NBAC task were used to measure inhibitory control and working memory, respectively. They're both classic measures of executive functioning or cognitive regulation. And in this study, we had a background noise on some conditions, but it was a social background noise. So this is like a babble stream where you take like 6 speech streams and you overlay them. And it sounds a lot like kind of a cocktail party effect. Participating children also watched 2 360-degree videos using a virtual reality headset while their autonomic responses were recorded. So I actually created those videos in collaboration with a team of graduate students at RIT who specialize in virtual reality. The first is a control non-social video of a playroom without any children. And then the second is a social video of a play date with multiple children. The videos were filmed such that the person who puts on the VR headset feels as though they were plopped right in the center of that room with all of the furniture and the children around them. And then I designed this video so children were making several increasingly social overtures as the video progressed. So it started with eye contact and got more and more social until we had duck, duck, goose all around that person wearing the headset. Finally, children and parents completed a couple of questionnaires. 2 brief questionnaires were administered to the children immediately following the 360 social video, and those assessed their perceived stress or anxiety during the video and their motivation to engage with the children from the video. So you can see a little example of a screen capture of one of the kids from the video, and then how much would you like to play with this child, basically. Parents also completed the brief 2 and the emotion dysregulation inventory. The brief measures everyday executive functioning, and the EDI was developed for use with children with autism to measure everyday emotional reactivity and regulation. So what did we find here? Well, I was pretty happy like that little kiddo. So we found really great tolerability of some of these more novel methods. So great tolerability of the wearable harness with 95% of tasks giving us usable data. And also the 360 videos in the VR headset. So 81% of children reported wanting to watch that social video again, like right away. They loved it. And all of the kids were able to watch both the non-social and social video throughout without any breaks. So that was really great. We also saw that there was the higher autonomic arousal and lower regulation from the lab during those EF tasks was related to more emotion dysregulation in everyday life. And that lower regulation during noise conditions of the EF tasks was related to sensory symptoms in everyday life. Okay, the last result for this study I want to show you examines the relationship between autonomic levels during social sensory challenges, I'll call them, and laboratory-based levels of social motivation. So that involved 3 correlations. The first graph shows that the higher heart rate during NBAC with social background noise was significantly associated with lower levels of social seeking behavior. So higher sort of stress levels during that task with social noise in the background relating to lower social motivation. The next graph is very similar. It's kind of the same thing, except we're seeing higher heart rate during the flanker task with social background noise being related to lower social motivation. And finally, the third graph shows that higher heart rate during that 360 social video was marginally associated with lower social seeking behavior. Controlling for the non-social video in that did not change the result. All right, so a brief summary and something for us to talk about here from study 3B. We see clear support for using these methods like I discussed. This is important because this was the first study to use 360-degree videos with children, autism and non-autism. It also was the first study to collect autonomic data to a virtual social scene in children. We saw evidence for concordance between laboratory and parent report measures of affective regulation and sensory dysregulation. We also see autonomic responses to those social challenges being related to social seeking behavior on that choose a movie task. So implicit or internal measures of regulation and motivation correlated with each other, but not with the parent report of social motivation from daily life. And that might be a particular kind of social motivation, which we should label as observed motivation. Because this highlighted piece is something I really feel like we need to emphasize, that appearing disinterested by conventional social standards is not the same as being disinterested. All right, tangible take homes again. The first one, that sensory and self-dysregulation should be important targets in social interventions for all children. So, in a mental health clinic, targeting self-regulation, that happens all the time. But typically when we're thinking about social interventions for autism, where we're teaching social skills, self-regulation is not a part of that curriculum. If someone has sensory differences, we're thinking about an occupational therapy referral for helping with teeth brushing or going to the bathroom. If they have emotional difficulties, we're referring for CBT or teaching them those emotion regulation strategies sort of in isolation. But I really think that some of our autism social skill programs should directly incorporate this regulation piece. It's also important for us to decrease sensory demands in learning and social environments to be more inclusive of people with autism. So creating safe spaces for individuals with ASD so they can participate and contribute in social, or educational, or even professional settings is an important way that neurotypical individuals can support their neurodiverse peers. That could look like hosting smaller social gatherings, being aware of the acoustics of an environment and minimizing background noise, maybe considering virtual options so people can participate but be in the comfort of their own space. And then also we can think about how we can use wearable physiological sensors and 360 videos in research and treatment with children with and without autism. So this could be very, very helpful for those individuals who are not yet using verbal language to communicate. Could also be very helpful when we're thinking about diagnostic processes, and I'll talk about that in a little bit. And then, of course, using 360 videos as a really neat way to do social exposures, working on that before an individual feels comfortable having some of those exposures out in the real world. All right, this is the final study I'll discuss here today, and it addresses an important research and clinical concern in autism. Whether self-report is a valid and useful tool for measuring internal constructs, in this case, sensory processing and anxiety symptoms. Unfortunately, many researchers and clinicians have long believed that individuals with autism lacked the insight and emotional awareness to report on their own symptoms. And that's a big problem, both for respecting the participation of autistic individuals in their own care, which is something we all should care about, and because it greatly limits the measurement of internal experiences by relying solely on observable behaviors. So this study sought to answer this question: does self-report of symptoms relate as well or better to internal physiological measurements as parent report of symptoms? To answer that question, adolescents with and without ASD and their parents completed anxiety and sensory symptom inventories that were like mirrored versions of each other. And then adolescents came to the lab where their heart rate was measured at baseline and while they completed a challenging computer task with background noise. First, I examined the sensory and anxiety questionnaire data by performing a mixed measures ANOVA for each scale. And for each, there was a main effective group and a main effective reporter, but no interaction between group and reporter. As you can see, and as we would expect, individuals with ASD showed significantly more sensory and anxiety symptoms than the control participants, and that was true for both child and parent report. You can also see that symptom scores were significantly higher when measured by child report than by parent report, and that was true for both the autism group and the typically developing group. Next, I wanted to relate the lab findings to those real-world reports of symptoms from the adolescents and the parents to look into this reporter discrepancy a bit more. In the graph on the left, you can see a significant relationship between child report of anxiety and baseline heart rate in autism. And in the graph on the right, you can see that child report of auditory sensory symptoms was significantly related to increased heart rate during the task with that background noise. Parent report of symptoms did not correlate with internal physiological arousal. And neither of these relationships show a significant relationship for the TD group, that typically developing group, but that's most likely because of reduced variability on those scales for those symptoms. So what did we learn here? Higher sensory and anxiety symptoms are present in ASD. That children reported higher symptoms than their parents, something we might not have expected, and that there is a correlation between child report of symptoms and their heart rate in autism, and that we didn't see that with parent report alone. So we really should be including self or child report of symptoms whenever possible, especially for internalized symptoms. So for adolescents and adults with minimal support needs, use just your regular standardized questionnaires and interviews. Give them that opportunity to complete those. For younger individuals or those with higher support needs, consider completing a questionnaire with the individual, or maybe using visual scales to support their understanding. And then, of course, caregiver and teacher report remains invaluable, but I would just say it's more valuable for constructs that have clear observable symptoms like externalizing behaviors. All right, so where do we go from here? I have a lot of ideas. Some at the top of my list include expanding study 3's feasibility study. I'm sure you could have guessed that. So we have some nice pilot data. I'd like to look at that in a larger sample with longitudinal data. And that would also allow me to look at that relationship in a bidirectional way. Maybe social differences are impacting self-regulation. We know there's a connection there. I also recently submitted an application for a department grant to address what is considered gold standard evaluation practices for autism, which unfortunately rely completely on caregiver report and clinician observation with very little consideration for internal experiences of the person being assessed. And we just saw that that's a problem. So we need to update that. Okay. In that study, I plan to use a wearable bioharness, the one I discussed earlier, to measure autonomic reactivity, which is during what's considered the core component of an autism evaluation, the ADOS. It's really a social stress task in a way, and it would be really interesting to see what those internal experiences look like knowing that many individuals with autism, especially those that have strong cognitive abilities and are older, are able to control how they're presenting, especially during a 45 to 60-minute interaction. So it's likely that they could look the same as other people on the outside, but maybe be working a lot harder on the inside to make that happen. And if that's happening a lot in day-to-day life, that has really huge impacts on their experience, their mental health. And so I would look to see if those internal physiological experiences, their self-report of their symptoms, and their self-report of that masking relates to ultimate diagnostic status as well as their mental health. And hopefully we can use that information to update our practices in the future. All right, I want to thank all of you for being here, the participating families, psychiatry leadership, especially Linda for really supporting me in expanding our autism program, and Steve for his research support and guidance. These studies happened in graduate school, so I really have to thank my graduate advisor, Louisa, and her entire lab. Jeremy Jameson is a psychologist over on River Campus who specializes in that autonomic psychophysiology component, so he was really helpful. Dr. Geigel from RIT, and then funding from the Organization for Autism Research and the department. So thank you all. Are there any questions?
Okay, well, while we wait for the questions, we have a question from Zoom.
Oh.
And that question is, given that autistic people can be hypo or hypersensitive to stimuli, how was it that all of the autistic groups in study 1 had lower sensitivity to stimuli than the neurotypical control groups?
Yeah, no, that's a great question. So first of all, that's looking at averages really within the group. So that's I think what they're talking about. Well, I won't bother you by scanning all the way back through, but that was really looking at that orienting response and the response over time. So if we collapse across the group of autism, we see generally less responsivity. And this gets back to that idea that sensory processing differences in autism are really difficult to kind of summarize in a really easy way. So sometimes we do see hyporesponsivity, sometimes we see hyperresponsivity. I think in this case, the best way I can explain it is that these are really controlled, low-level stimuli. So having a tone just go boo, boo, is really different than sitting in a classroom and all of a sudden the fire alarm goes off. And that's that more complex, aversive kind of sensory input that we typically see that hyperreactivity to. So that's what I would say for that one, but it is complex.
Okay. Any questions from here? Anna? Remember to wait for the microphone.
Hi, Jess. This was lovely. Thank you. At the end, when you were talking about your future directions, I was thinking a little bit about research on parent co-regulations. I know very little about it, but I was curious if you do and if you've thought about integrating that in at all, especially I think if we think about how you might translate it to intervention work and parents are serving as coaches in the home, like how their own autonomic regulation might play a role. Do you have thoughts on that?
Yeah, like a dyadic interaction. Yeah, I think that would be really cool. Jeremy, Dr. Jameson has done some of that work too, looking at dyadic processes with autonomic regulation. And I think that would be excellent to incorporate. And that's exactly why I mentioned that idea that the social motivation or social functioning likely also back impacts self-regulation. So I think we'd have to go much younger in order to look at that, or I would want to go much younger in order to look at that to see how things are developing early on, knowing that a dysregulated little guy is often going to dysregulate a parent, and just what does that look like over time as it unfolds. But I think it would be very helpful. And interventions, like we have a parenting intervention in our clinic that really helps parents become more mindful of their own regulatory state. Things like that could be helpful. Yeah, absolutely.
All right, well, I have some questions for you.
Oh, awesome.
So going back way to the beginning,
Yeah.
the lack of the orienting response
Yeah.
and the heart rate. You had talked about that in terms of like hypo-responsivity, and maybe people adapt by, spinning or doing stimulating things. But is it possible that that is resulting from too much internal noise, basically, and that's why they don't
Yeah.
show the suppression?
Possibly. Yeah, I haven't seen data that directly supports that, but I could see how that would fit with this sort of outside lay view of being in their own world that you often hear about when you're thinking about autism. I think that it's probably also due, and this is sort of related to effects like down-regulating effects of chronic stress from sensory input as well. So these were teens we're looking at. And there has been some research that's shown that if an individual has been exposed to this more aversive sensory experience for a long time, they down-regulate. And so that could be a component as well. In terms of like internal, say more about the internal noise. Thoughts, internal noise in terms of physiological sensations. What are your thoughts on that?
Well, now pressure's on me, but as long as I guess to jump to the end of what I was thinking was, I wondered if these people, the young people you studied, are kind of, I don't know, over aroused or have too much excessive mental activity happening. And then when you mentioned they don't respond as much to repeated stimuli, I wondered about habituating more quickly. And it just reminded me of some data from years ago, offspring of parents with schizophrenia, where a lot of these kids had very strong reactions to sensory stimuli and extra fast habituation. And the idea was that thought disorder started to emerge in them. It was essentially reinforced through classical conditioning, and that their distracting thoughts would get reinforced because it would reduce the anxiety. And I just wondered with some of these kids, if some of the social avoidance is reinforced in the sense that it lowers anxiety, that they're more prone to have a quick drop in anxiety through sensory noise lowering. When they're just by themselves. So is there any evidence of that?
I think part of it is, we controlled for baseline. So whatever internal baseline kind of noise they have going on was controlled for when we were looking at the reactivity. The habituate or the orienting response at the beginning was really to those first couple like stimuli. So the first couple tones, for example, we looked at the habituation over time and didn't really see a big difference in how autism responded compared to the control group. So in my data there, not a ton of evidence for that, but I can see how that could happen over time, like in the real world, having to down regulate just as a way to deal with the stress of it.
Okay.
Yeah.
Thank you.
Yeah. Anything else?
Linda?
This is a long question, but just a short response will be fine, given the time.
Okay.
But I guess I'm wondering if you could just talk a little bit about your thoughts about the school setting and what your recommendations would be for modifications in school programming for kids with ASD, because it seems like such an aversive experience for so many of them. So I was just wondering if you could share a few thoughts about that.
Yeah. My advisor and I in grad school, we actually went to a school and recorded noise from classrooms and cafeterias, and calculated just like the loudness of it and the complexity of it. And it's a lot, especially in younger years when people are breaking off into groups and all chatting amongst themselves. So I think one thing to consider are what are some individual sensory coping strategies that that person can have control over? So I frequently recommend like the Loops earplugs that filter out unwanted background noise, but still allow like a teacher's voice to make its way through. So that's great. And it's less stigmatizing than maybe the larger over the ear headphones, although those could be helpful if someone's maybe working on a test and really needs to block everything out. So I think that's one thing. Same thing with the upregulating, having different tools that they can have, and educating the teachers on that, because I've often heard, well, the fidgets are distracting to other kids. And so really working on what's going to be right for the classroom. But then some of it is going to be at the classroom level and the school level. Like I get concerned when I don't know the school data on this, so I'm a little outside my scope, but I get concerned when I hear about the schools that have like no walls between all of the 4th grade classrooms, or that sounds like a little bit of a nightmare. So offering this other perspective that like, yeah, that might increase community and all of that, but you have a lot of learners who have autism and don't have autism, right? That are impacted by sensory input, and that might be hurting learning. Just a few thoughts. Yeah, of course.
Okay, well, with that, we are just about out of time. I want to thank everybody for coming today, and thanks you,
Thank you so
Jessica, for
much.
a really fascinating presentation.
Thank you.
Have a good day, everybody.